السلام عليكم، مساء الخير جميعا.
عليكم السلام ورحمة الله دكتورة زينب.
أهلا دكتور أشرف، أهلا دكتور عبد الله،
أهلا دكتور.
والمنظمين أكيد. أستاذة فاطمة في ملتقى الخبرات، يعطيكم العافية.
الله يعافيك يا رب. أهلا فيك.
الله يحييك دكتورة زينب.
أهلا دكتور عبد الحفيظ، كيف الحال؟ إن شاء الله
والله
بخير.
بخير الحمد لله، كيف صحتك؟
الحمد لله تمام، يعطيكم العافية، وإن شاء الله يكون ويبينار ناجح بإذن الله.
إن شاء الله.
خلاص نبدأ الآن مع دكتور عبد الحفيظ.
أتفضل دكتور أشرف.
أوكي. طيب. بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Respected colleagues, distinguished audience, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event where we are here, all of us together, to share knowledge and exchange experience in a very important topic that is related to vaccinations and infectious disease, with a special focus on shingles. And this is one of the episodes of the Shingles Masterclass. This is under the collaborations with the Saudi Society for Family and Community Medicine. And I would like to thank GSK for sponsoring this event where we are here, all of us together. And I would like to extend my thanks for the organizers, Fexus Company, for their organizations. And I'm very sure that today we have been privileged to have two eminent and prominent speakers in the field with their wealth of expertise. I'm sure that they're going to bring a lot of ideas, insight, experience into our discussion today. And definitely this will be impacted, inshallah, our clinical practice in order to make it more efficient and more sound from the medical excellence point of view. But before I start, ladies and gentlemen, let me set up the stage by saying that there was only 3 discoveries in the medical field that saved the humankind and saved the death and the life of humankind across the different stages of human being. One is the discovery of insulin, the discovery of antibiotics, and the third one, which is a very important one, the discovery of vaccines. And that's why we are here together to share this novel discovery and to shed light on its importance. But unfortunately, when we look into the vaccinations coverage in our societies and globally, unfortunately, majority of our population, they think that the vaccine are only and just only for kids and children. Adults remains vulnerable, and we have in our community in the Kingdom of Saudi Arabia, vulnerable populations, elderly patients above the age of 60 and plus, as well as the high epidemicity of chronic disease, diabetes, hypertension, obesity, and cardiovascular disease push our community to be at that particular vulnerability and sensitivity to the reductions of their immunity and immunosynthesis to make them more subjected to these kind of infections. And of course, when we talk about adult vaccinations, we have influenza, pneumococcal vaccine, hepatitis B, meningococcal vaccination, and herpes zoster. And of course, the burdens will increase as we advance in age. And according to the Kingdom of Saudi Arabia, the expanded program of immunizations secure a great success in pediatric coverage. But how about the adult vaccinations? Still, we are below the optimal state, and still there is a lot of effort has to be paid. And in fact, you have seen a lot of campaigns. One of it, the Shingles campaign, which was one of the important and successful initiative that changed the landscape of the coverage to some extent. But again, we have to go ahead with a lot of effort, with a lot of power to move ahead. So ladies and gentlemen, today in our sessions, we have certain objectives. One of the objectives is to enhance our awareness and understanding about the importance of the life course vaccine as a very important strategy, maintaining the health and to prevent the disease among all age group, with a special focus today on elderly patients. This is number one. And the number two is to highlight the burden and the unmet medical need for herpes zoster in spite of all these efforts, and the impact of the quality of life of having these people subjected to the complications of herpes zoster. And then we are going to shed the light on, or to put some kind of insight on the vaccinations for prevention of herpes zoster. So I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant family medicine. I'm the Chief Medical Officer of IMC Group and a member of the Saudi Society of Family and Community Medicine and the president of the IMC Family Medicine Club in Jeddah. So I'm being privileged to be part of this wonderful gathering. I have no interest, but I have received an honorarium for the GSK for moderating the session. And as you can see, our session is just only 2 hours. We have 2 presentations, but the good part of this presentation that we will have some kind of polling questions, a kind of knowledge check. So please try to scan the barcode that you will be having from time to time, and make sure that you use the laptops rather than the mobile in order to have more accessibility to scan the code and to get live in the voting system. So, so we are going to talk about the importance of the life course immunizations, and then this will be followed by the herpes zoster disease and unmet medical need. And then there will be a discussion. So I would like to urge you all to put your questions in the Q&A box, and then I'll be able as a moderator to select those questions which is relevant to our sessions and have a fruitful discussion. So, so I would like to start by introducing our first guest speaker, Dr. Faiza Nahdi. She is a consultant infectious disease in Prince Sultan Cardiac Center in Riyadh. And I'm sure with her wealth of expertise, she is going to talk about a very important topic, which is the importance of the life course immunizations. So on your behalf, ladies and gentlemen, I would like to thank Dr. Faiza for accepting our invitation and being part of this wonderful scientific gathering. So, Dr. Faiza, I would like to leave the floor for you. Tafadali.
Can you see my slide? Assalamu alaikum. Good evening, ladies and gentlemen. Thank you for the Saudi Society of Family and Community Medicine and GSK for this valuable collaboration. I'm pleased to be with you, and on this timely, valuable webinar, my talk will shed light on life course immunization importance and value in general. So you can see my slide.
Yes, we can see. I think, can you move it a little bit, Doctora? No.
Yes. You can see it now?
I think I have to get out of. I should stop sharing.
Is it clear?
Yes, Dr. Faiza, you can
Yes,
start.
we can see it, Doctor.
So vaccination is one of the most powerful public health interventions, second only to safe water, in terms of saving life and improving population health. Even antibiotics do not cause close or even close to vaccinations when it comes to reducing mortality. Without vaccination, we would face high mortality and severe morbidity and enormous global financial burden, measured not only in healthcare costs, but also in lost productivity and long-term disability. On the other hand, vaccine fuel the economic growth by keeping people healthy, reducing healthcare demand, and enabling our children to grow up healthier and contribute productively to society. So vaccination is not just a medical intervention, it is an investment in both public health and economic stability. Today, vaccinology has moved toward the new concept called life course immunization. This means that vaccination is not just for only children. It is essential at every stage at our life, including adolescent, adulthood, and elder age. When we come to older adults or elderly, remain vulnerable to disease, influenza, COVID, shingles, and others. Vaccine helps protect them and maintain a good quality of life. So vaccination are not just about protecting children, they are lifelong shield for everyone, contributing to the healthier agings and stronger communities. This slide highlights a surprising important fact in US where more adults die from vaccine preventable disease than children. Even every year, around 42,000 people in US die from disease that could have been prevented with vaccine. And remarkably, 99% of these deaths are in adults. Overall, the prevalence of vaccine preventable disease is higher in adults than in children. As you see here in this graph, uh, and this image show that nearly the entire burden of vaccine preventable deaths is among adults. So when we talk vaccine, it is not just a childhood issue. In fact, improving adult vaccination rate could save 10,000 of life every year. One key reason for that adult vaccine covering is low, while children usually follow a strict vaccination schedule. That make their the disease burden is less in children, as we can see here in this image. Moving to changing demographic, as people live longer, the age structure of our society has changed dramatically, and this directly affects how need to think about vaccination, how we need to think about vaccination. In early 1900 life expectancy was only about 60 to 65 years, and there was a high proportion of children in this population. Because of this, public health efforts, including vaccination, were focused mainly on children. For this immunization program were designed around the childhood because infection and mortality were highest in young age group. Today, people live about 80 years, and 80 on average. Our population now include a much higher proportion of older adults compared to 100 years ago. This demographic shift means that limiting vaccination to children no longer meets our society need. To meet the changes of aging population, we need a life course immunization and vaccination strategy that protect not only children, but adults and older adults throughout their life. The goal of a life course immunization is not just preventing disease. It is about helping people live longer, healthier, and more independent life. Just like exercise, good nutrition, and medication, vaccine are part of lifelong strategy to stay healthy and age well. This was a population-based prospective cohort study at around 260,000 adults aged older than 45 years in Australia, conducted between 2006 to 2008. This study found that the incidence of pertussis notification did not differ by age, but hospitalization rate progressively increased by 2.2 in 45 and people between 45 to 65 years, and 8.5 in 65 to 70 years, and 13 in adults more than 75 years. The study concluded that adults more than 65 years were more likely to have hospitalization. So the effect is more in adults. I think we have.
Yeah. Thank you so much, Dr. Faiza. And now I think we'll move. I would like to request the audience to just scan the QR code and be ready for the questions. Okay. Dr. Faiza, can you flip? Next slide. Yes. So the questions for you now we have, which one of the following has had the greatest effect or on reducing mortality apart from safe water, antibiotics, vaccinations, improved nutrition, exercise? So this is the question. So you can select the right answer and we will be able to see the result. Okay. I will go to the second question. Why are older adults at higher risk of hospitalization with infectious compared to younger adults? Is it because they have stronger immune system, they have weakened immunity and comorbidities, they are more exposed to children, and they receive more vaccines? So these are the two questions. I'll give you 30 seconds. And then we'll see the results. Okay, let's see the result. Okay, so this was the first questions. Which one of the following has had the greatest effect on reducing mortality apart from safe water? Definitely it is vaccinations, because this was one of the remarkable things that save life and maintain people safe. The second question is, why are older adults at higher risk of hospitalizations with infection compared to young adults? Definitely because they have weakened immunity and comorbidities. And this is a fact. In fact, majority of our elderly patients, they have immunosensitivity and they are having a health that is associated with comorbidity, chronic disease, and so forth. So majority of you, they have answered the questions. So I think this is a good response to the presentation. Okay, so we can continue, Dr. Faiza, please.
So moving to our vaccination strategy. This study shows that benefits of vaccination program can extend beyond the direct effect on target populations. When influenza-related mortality rate in Japanese adults aged more than 65 years was reduced through herd immunity, and from 1994 onward, the priority group for vaccinations were adults and high-risk group. There was initially an increase following and a decline in the number of deaths. So when the children received the immunization, the hospitalization and mortality were less in the adult by herd immunity strategy. Here, another strategy can be figured when measles has re-emerged in Europe due to suboptimal immunization level. Measles cases increased more than fourfold between 2009 and 2018, although the highest number of cases was in children under 1 year of age. There were also significant number in teenagers and young adults and people more than 30 years. This highlights the need to fill immunization gap in older individuals who have not received vaccinations and in whom vaccinated acquired immunity has waned. Example of how accumulations of unvaccinated individual can drive outbreak is shown here when the disease burden of rubella in China has been gradually shifted to older age group. In 2006, most of the rubella cases were concentrated in an individual between 15 and 19 years of age. This shift is due to incomplete coverage among children and accumulation of unvaccinated individuals. Talking about our immunity with time, this slide summarizes the main reason why older adults are more vulnerable to vaccine preventable disease. Weakened immune system. This process known as immunosenescence, diminished response to therapy, use of multiple medication, delayed diagnosis because they usually have atypical symptom at presentation, so accurate diagnosis difficult to reach at some time. Some elderly live in a long-term care facility. Underlying medical condition and comorbidity like diabetes, heart disease, and kidney disease. Together, these factors can create higher susceptibility to vaccine and preventable disease among older age group. This graph clearly shows how aging impacts the immune system and increase the risk of severe infection like pneumonia. Here we see the incidence of hospitalization for pneumonia in Australia from 1998 to 2004, grouped by age. By age, children under 2 years, the hospitalization rate is high due to immature immunity as expected. The rate drop then stay low through adulthood, and around the age of 65, we see sharp increase. This steep rise demonstrates the impact of immunosenescence. This is an evidence to reinforce the need for prevention strategy like vaccinations. What is immunosenescence and how does it affect immune system? The immune system change over an individual lives. In a newborn, this is an immature system, leaving them at risk of infection. It develops through childhood into adulthood, but then gradually weakens with age and and with a concept called immunosenses. As a result, older individuals are more susceptible to vaccine-preventable infections such as herpes, influenza, pneumococcal, tetanus. Therefore, there is a need for a vaccination program that protect individuals through all stages of their life. Immunosenses is the term used to describe the natural age-related decline in immunity. This features of aging has a major public health implication since it impairs the ability not only to compete infection, but also to develop protective immunity following vaccination. The mechanism of immunosenses are complex, but a substantial body of evidence shows that intrinsic defects appear in both innate and adaptive immunity. These figures show how immunosenses affect several different cellular components of the innate and adaptive immune system. It affects hematopoietic stem cell ability to renew B cell productions and alter the cytokine productions as well, and T cell and memory cell interactions with infectious agents. Dr. Ashraf?
Okay, thank you so much, Dr. Faiza. Now, please make sure that you have scanned the QR code, and we'll move to the third question. Next slide, Doctor. Okay, so the question is, what is immunosenescence? Is it early maturations of immune system, or is it age-related decline in immune system function, or enhanced immune response in old age, or finally, immunity gained from vaccines? Okay, 30 seconds. I think Dr. Faiza, she was very clear in describing this terminology, so I think it will be easy for everyone to capture the right answer. Okay, the second question, Dr. Faiza, لو سمحتي. طيب, which type of immunity declines first with age? Is it humoral immunity or cell-mediated immunity, innate immunity, or antibody response only? So 30 seconds. Okay, we'll see the answer. Okay, so what is immunosensisis? It's age-related decline in immunity system function. You got almost 68%. They have reached the right answer. So it's not an early maturation of immune system. It's a declining in the immune system, in fact. So the first answer was not right. The third one, enhanced immune response in old age. Usually the immune response gets lower, so it's not the same. Immunity gained from vaccinations. No, this is not immunosensitivity. So, so the right answer is age-related decline in immune system function. So just remember this terminology because it's very important for us to memorize it and to use it to describe the age-related decline in immune system function. Next question, please. Okay, which type of immunity declined first with age? Is it humoral immunity? No, of course. Is it cell-mediated immunity? It's only 41% of you, they have answered, and this is the correct answer. And this is usually due to the thymic involutions, the thymic shrink after the puberty, leading to fewer native T cells being produced, and all the others show reduced T cells proliferation. So that's why, and the cell-mediated immunity is the first to decline with age. Innate immunity, That's the right answer, and antibody response only is not the right answer. So the right answer is the cell-mediated immunity is the first immunity decline with age. So thank you. We will continue. دكتورة فايزة تفضلي.
Yeah, so moving to approach to adult immunization, to highlight key considerations for implementing a life course immunization approach with a goal to maximize disease preventions and improve overall health and well-being by a close childhood immunizations gap in adolescents and adults, immunization in elderly adults, maternal immunization, addressing antimicrobial resistance, optimal health, travel-related immunization, challenges due to chronic condition, or immunodeficiency, immunization need due to migrations. Vaccination in older adults not only clinically important, but not only clinically important, but also a cost-effective public health strategy that supports healthy aging. Certain vaccines help to prevent disease that are not fatal, like herpes zoster and pertussis, but these vaccines enhance the quality of life by reducing pain and other symptoms. While on the other hand, influenza, pneumococcal, hepatitis, diphtheria, tetanus vaccines lower the risk of severe illness and mortality. This slide shows what does life course immunization involve with vaccination calendar that tailored to different life stage and meet individuals' need throughout their life. During infancy, adolescent, traveler, pregnant, and older age. What does vaccine coverage look like in adult? This summary of the vaccine recommendation in adults more than 18 years of age in Europe countries, influenza, and as you see, influenza, pneumococcal, and are highly recommended. Here, this figure shows vaccine coverage in US. Vaccine coverage in US based on CDC analysis. Coverage for flu, pneumococcal, and tetanus was relatively high and low in hepatitis and herpes, and several factors that has been identified that contribute to this, like ethnic differences, lack of awareness, lack of recommendations, lack of systematic assessment of vaccination status. So in order to improve adult vaccine coverage, guidance was published by National Vaccine Advisory Committee to assess vaccine status and offer vaccination and recommend vaccinations. Here, this slide displays some of the novel vaccinations. Sorry. This slide displays some of the novel vaccination strategy that could help to improve vaccine response in older adults. Life course immunization, designing a new vaccine that are effective in children, adult, and older adult to increase coverage and promote herd immunity, increasing vaccine antigen content compared with a standard dose vaccine to induce a stronger immune response, which is older adults need. Alternative delivery route like intradermal injection to promote a better local antigen response and uptake. Use of adjunctive to induce a stronger innate immune response. Communication is a critical part of vaccination success. Healthcare professionals play a key role in shaping public attitude toward vaccination. Education, providing reliable information and using patient-friendly language and reinforce an understanding of benefit and risk of immunization will increase the awareness of vaccination, and this will come to a success of vaccination, any vaccinations campaign. Vaccine is a shared responsibility across the entire healthcare system, and among these, pharmacist role is becoming more central as they are the most accessible healthcare work professional. Dr. Ashraf?
طيب, yes, we have, thank you, Dr. Faiza. We have another set of questions. So already you have scanned the code. Okay, we'll go to the next question, please. طيب, which factor contribute to low vaccine coverage among adults? Is it strong awareness campaigns or lack of healthcare providers' recommendations, easy reimbursement system, and abundant vaccine supply? So 30 seconds to have the right answer. Okay, we'll move to second question. Okay, varicella zoster virus cause which two diseases? Measles and rubella, or influenza and pertussis, or varicella and herpes zoster, or diphtheria and tetanus? So which one is the right answer? Which two diseases caused by varicella zoster? 30 seconds. Okay, we'll have the answer. So the first question is, which factor contribute to low vaccine coverage? Definitely, it's a lack of healthcare provider recommendation, and this put a huge responsibility on all of us as a vaccine promoter and vaccine recommenders. Unfortunately, because of the vaccine hesitancy, this has to be counteracted by our full power of recommendation of vaccine to make it viable and to make it more convenient and convincing to the people to have it, especially elderly patients with a low immunity. So the right answer is HCP recommendations. It's almost about 77%. I wish it was almost 100 because this is a mindset that we have to keep in mind all the time. Thank you. Next question, answer. Varicella zoster virus causes two diseases. Definitely, this is 89% of the answers are correct. Varicella and herpes zoster. Varicella in the childhood and herpes zoster in adulthood. So chickenpox and herpes zoster. These are the two diseases which causes by varicella zoster virus. Okay, thank you so much for your active engagement and active participations. Next, we'll go ahead. Okay.
So coming to conclusions, despite the availability of several vaccine licensed for use in older adults, data indicates that vaccination coverage remains low. Furthermore, elderly exhibit lower vaccine responsiveness. Healthy aging is critical to social and economic success in the society. Making preventive health services such as vaccination accessible to older people has been recognized by WHO as a global strategy on aging and on aging health. Beside other strategy, but the vaccination is one of the more important. Last, I will conclude my talk by these take-home messages. the community is at increased risk of vaccine preventable disease because of the demographic changes. Life course immunization can change the demographics and healthcare priorities. A vaccine coverage among elderly is still low. Successful immunization depend on the acceptance by healthcare provider and public health. The strategy should be tailored according to the target populations.
Okay, I think we have some more questions. Okay. Let's go for the question, please. Which vaccines are recommended for older adults? Influenza, pneumococcal, pertussis shingles, or MMR, polio, rotavirus varicella, dengue, rabies, typhoid, cholera, or HPV, hepatitis A, rubella, and HIV. Okay, next question. What is the most common complication associated with herpes zoster? Is it pneumonia, or post-herpetic neuralgia, or meningitis, or skin scarring? Okay, we'll have the answer. So which vaccine are recommended for older adults? Influenza, pneumococcal, pertussis, shingles. Correct. So this is the right answer. It's almost 86%, which is the correct answer. Okay, the second one. So what is the most common complication associated with herpes zoster? Definitely supports herpetic neuralgia, and this is a very devastating complication that impair the quality of life of patients and subject the patient to be vulnerable, not only physically, but also psychologically as well. So all the time we vaccinate patients to prevent multiple complications, with the worst one is the post-herpetic neuralgia in herpes zoster. Okay, thank you. So with this, I would like to thank you, Dr. Faiza, for wonderful presentations. It was quite illustrative and quite informative. So you shed light on the importance of life course immunity, immunizations, and you mentioned the decline of the immunity with aging, and that's why most of our elderly population are vulnerable for infectious disease. And you mentioned very elegantly the adult vaccination coverage strategies, and you ended your presentation by putting a responsibility on the HCP for having the proper and effective communications in promoting vaccinations and to tackle the vaccine hesitancy. With this, on your behalf, ladies and gentlemen, I would like to thank Dr. Faiza for her wonderful contribution for this session. And now we will move to the second guest speaker, who is well known for us, and we would like to thank him for accepting our invitation, Dr. Abdullah Zahrani. He is Associate Professor, Consultant Family Medicine, Diabetologist, King Abdulaziz Medical City in Jeddah, and he's going to take us all the way to complete the journey of our adult vaccination to put more focus on herpes zoster disease, the unmet medical needs. So we will be eagerly waiting to hear from Dr. Abdullah, his presentation and his thoughts and expertise in this topic. Tafadhal, Dr. Abdullah.
Thank you, Dr. Ashraf. It's my pleasure to be with you today, and special thanks to Saudi Society for Family and Community Medicine and for GSK for inviting me and for the organizing committee. Slide, is it okay?
Yes, it's clear, Dr. Abdullah. Tafadhal.
Okay.
You can flip it. You?
So yeah, it's
تفضل.
okay.
Yes,
Yeah.
it's okay now. Yes.
So to start with disclaimer, I'm not a GSK employee and I received an honorarium from GSK for this presentation. And my presentation will be about the herpes-zoster disease and unmet medical needs. So I'll try my best to highlight an important objectives in terms of discussing the risk factors which is associated with herpes-zoster and the risk for developing such infection, and to discuss the main role for cell-mediated immunity in terms of activation of herpes-zoster, to discuss the severe associated complications, especially in elderly with comorbidities and in immune-compromised patients. Last but not least, we'll talk about the importance of herpes-zoster vaccine, especially for the age group more than 50 and in immune-compromised patients. So to start with basics regarding varicella zoster and what disease does it cause, it's a herpes virus. Usually it causes primary infection in children as chickenpox and became dominant in the dorsal root once reactivated secondary to declining in immunity, as clearly described by my colleagues Dr. Faiza and Dr. Ashraf in terms of immunogenesis. So there will be a virus reactivation, and it's a highly contagious disease, acute infectious disease, characterized by pathognomic features, which is itchy, vesicular rash. And when there is a reactivation of dormant virus, it can cause herpes zoster later in life. And it's associated with, let's say, a cutaneous complication with itchy rash. And sometimes many patients develop something like post-herpetic neuralgia. It is one of the most common complications associated with herpes zoster, and we will highlight about it in the next slides. So which age group at a risk for developing herpes zoster? Based on different studies worldwide in USA or in Europe, more than 90% of adults showed the serological evidence of herpes zoster infections, reactivations. And it's very common, especially with advanced age, secondary to declining in immunity. And it is higher, especially for the age group more than 50 years and immunocompromised individuals. I'm sure that you are aware about the disease course and the herpes zoster symptoms. So the natural course of herpes zoster start with prodromal symptoms or phase, followed by acute phase, and subacute phase end up with complications like post-herpetic neuralgia. So in the beginning, the prodromal phase, usually it started or takes from 4 days to 2 weeks by general symptoms in terms of headache, photophobia, malaise, abnormal skin sensations, and less common to present with fever, followed by the acute phase, which lasts 2 to 4 weeks, associated with unilateral vesicular rash and associated also with acute pain, followed by the subacute phase. It may last up to 3 months. Some patients, they develop post-herpetic neuralgia, which may last months or even sometimes years. So post-herpetic neuralgia, it's very common associated complications. It's a neuropathic pain and usually persists more than 3 months or 90 days after the onset of herpes zoster rash. So these are the natural course of such disease. Epidemiological or the global epidemiology for herpes zoster, they found in different studies worldwide that the age is the dominant driver for herpes zoster. And as the age increases, the risk of herpes zoster due to immunogenesis and this seroprevalence lifetime risk worldwide, more than 90% of adults, they are at risk to develop latent varicella zoster virus, and up to 30%, 1 in 3 people will develop herpes zoster in their lifetime. up to 9% of patients, they experience herpes zoster recurrence. And this is very important because we will highlight about this information in the next coming slides. So based on different studies worldwide, they found that the incidence rate of herpes zoster by age were similar among different countries. The incidence rate reached to 6 to 8 cases per 1,000 per year, especially at the age of 60. We have different studies from Australia or Asia and Europe, and it showed such incidence. So how about the associated complications? All of you know that herpes zoster associated with wide spectrum of complications in terms of post-herpetic neuralgia. As we said earlier, more than 30% they develop such complications. Some patients, they may develop vascular complications in terms of stroke or TIA, transient ischemic attacks, or myocardial infarction, up to 0.7%. And usually they develop such complications within 3 months of herpes zoster virus infections. Another important associated complication in terms of neurological complications, namely encephalitis, meningitis, pulses, nerve pulses. If it involves the ears, it can lead to Ramsay-Hunt syndromes. If it involves the eye, it can lead to zoster ophthalmicus. And they found that it can associated as a complication up to 15%. And if developed, the eye-related complications sometimes reach to 80s in patients with herpes zoster ophthalmicus. So approximately, based on different studies and based on the literatures, approximately 10% of patients with herpes zoster aged more than 50 years experiences more than or equal to 1 non-post-herpetic neuralgia complications. So this is very important from clinical point of view to screen patients about the possible associated or the wide spectrum of associated complications with herpes zoster. When we go close to a common associated disease or comorbidities, patients with diabetes frequently have associated complication in terms of CKD, chronic kidney disease, or cardiovascular disease. And interestingly, they found in studies there is like a bidirectional relationship between diabetes and herpes zoster. Patients with diabetes present with low immunity secondary to the main pathophysiological changes and the effect on immune system, which lead to put the patient at a high risk to develop herpes zoster or reactivation of Perizilla zoster. And in the other part of the coin, the patients or the diabetic patient who develop herpes zoster, they are more prone to have, let's say, post-herpetic neuralgia. Sometimes it takes months or even years. It affects the control. So up to 25% based on studies that they found to have high A1C. So if the patient, let's say A1C is less than 6.5, with such infection, we may go beyond this. So we may have more than 25% increment in the A1C, which may reflect it in morbidities and the requirements for further intensifications of medications and hospital stay or length stay for patients if they develop further complications. So when you go more basics regarding patients with diabetes, they have reduced activations of the protective innate cells and shared with other comorbidities like CKD or cardiovasculars. They found that they have an increased production of pro-inflammatory cytokines and they have reduced expressions of microbes killing peptides. And the same thing applies for CKD, at which they have significant reductions of the defensive cells in terms of T and beta cells, and the increased productions of pro-inflammatory cytokines and accumulations of uremic toxins. So all these factors lead to or keep the patient more prone to develop such infections. That's why we have to have something called a bidirectional relationship. So, in generally speaking, viral diseases in terms of influenza, COVID-19, or even herpes zoster, shared the main or the common inflammatory process in terms of high inflammatory cytokines or hypercoagulable status or plaque destabilizations, which may lead to deteriorating of the chronic conditions in terms of diabetes or CKD or cardiovascular disease. And on the other part, patients with chronic disease, they are susceptible to develop viral disease in general, secondary to low immunity. And so regarding the herpes zoster and comorbidities, we found or studies showed that diabetes consider one of the main risks at which patients they are at risk to develop reactivations of the varicella zoster. And interestingly, they found that the risk of herpes zoster in patients in diabetes, when they stratified it by age, they found that patients more than or equal to 50 years of age, they are more risk. So we have to consider it. And that's why now it's recommended to give such vaccine for the vulnerable group for those more than or equal to 50 years. Another important finding based on different studies that patients with multiple comorbidities, they are associated with high risk of herpes zoster. So patients with, let's say, single comorbidity or 2 or 3 comorbidities, they found that as the number of comorbidities increase, the risk of developing herpes zoster will be increased, as you can see it in the graph on your right side, especially and that was associated with an increase in age and increased on the number of comorbidities. And the same thing apply for the associated complications, IA post-herpetic neuralgia, which is one of the common devastating complications. And the risk of post-herpetic neuralgia in patients with diabetes was high, and it may persist more than 6 months, and it need, let's say, further interventions. Some patients, they may require referral to a pain clinic because they are not responding to the usual medications or the painkiller medications. So it's common, and the risk post-herpetic neuralgia can be present based on studies in Taiwan that it can present in both type 1 and type 2 diabetes. They are both have higher risk of post-herpetic neuralgia. So it's important in our clinical setting that we have, since once the patient develops such infection, so we have to be careful and with regular monitor and follow-up and to see the risk to develop such complications. And if they develop it, we have to tackle it with appropriate intervention. So we mentioned early that it is a bidirectional relationship. So if the patients or diabetic patients develop herpes zoster, so they are at risk to develop complications in terms of post-herpetic neuralgia. They may require further intensifications of medication, whether the patient in oral medications or in insulin. So we have to intensify treatment because the patient may present with hyperglycemia. And they found by studies in 2017 that patients with diabetes, they are at risk to increase in A1C by 24%. For example, patients present with less than or controlled status, they became uncontrolled. So we have to be careful. Patients who develop complications and with admissions, it can lead to further hospitalizations, and it may affect the cost and affect the healthcare system. And if the other associated complications like length of hospital stay or further intensification of medications was also found with a diabetic patient who developed such infections. So I'll highlight 2 important cases, and the main take-home message is, could we prevent such cases or the complications? So the first case to present is 70 years old male patient with a past history of diabetes and hypertension. The patient developed a right side chest painful rash with fever, and the rash resolved after 10 days, but the patient's complaining of persistent burning sensation. And this presentation affect the quality of life since the patient cannot sleep or do daily activities. And this pain persists for more than 4 months, and the patient developed depression, which is common scenario faced in our clinic. And the question is, could this have been prevented? Another case is 50 years old female with a history of diabetes, and she had a history of chickenpox before while she was child. And she is very concerned because her husband developed shingles 2 months ago, affected his right eyesight, resulting in corneal ulcers and blurred of vision. And she came to your clinic and she's very worried about herself. And the question is there anything to offer as a protection? So again, these two important clinical scenarios, you may face it in your clinic. So we will highlight the answer for such cases. So when we look to these two cases, the first or the three questions that can be raised, what do they have in common? The second question, is there anything to offer as a protection? And could this have been prevented? So regarding the natural history of varicella zoster, all of you know that patients, the beginning, they start to have chickenpox, and then the virus itself became predominant in a dorsal root, and there is no symptoms. It may last years. Once the patient had a risk factor, especially with advanced age and low immunity, there will be a reactivations of the herpes zoster, and that lead to the development of herpes zoster. So this is the clinical or the story of the patient. So they start with chickenpox, and then the virus goes through the latency or in the dorsal root ganglion. Once reactivated, it presents with varicella zoster, and it can present with different presentations and in terms of local skin infections, or if it's associated with infection to the eye, or it can cause zoster ophthalmicus, or even for the ear, it can lead to Ramsey-Hunt syndrome. So risk factor is very important when you deal with patients with herpes zoster. In the history point of view, we have to ask about different conditions or risk factors. If the patient received, get the infection before, if the patient had a physical trauma, if the patient is having immunosuppression status of the patient, let's say on steroids or chemotherapy, psychological stress, other comorbidities like diabetes, autoimmune conditions like rheumatoid arthritis, SLE, inflammatory bowel disease, COPD, renal disease or cardiovascular disease. So it's very important when you deal with the patients or to see or to do what we call risk stratification. So based on that, you put your patient that if he's having high risk or she's having high risk, and you deal with it accordingly.
Okay, thank you so much, Dr. Abdullah. Now we will have another knowledge check. Question number 5. So please scan the QR code and try to scan it from your laptop rather than the mobile. So we'll go for the question, Dr. Abdullah. So the most likely diagnosis in these cases is varicella, chickenpox, herpes zoster with post-herpetic neuralgia, eczema herpeticum, or contact dermatitis. So which is the most likely diagnosis of the case? Okay, we'll go for the second question. Next. Right. The risk factors that increase the likelihood of herpes zoster and its complication include all except MADA, advanced age, diabetes mellitus, hypertension, regular exercises. So what are the risk factors? that increase the complications except. Okay, now we'll go for the answers. Okay, so the first question, the most likely diagnosis in the cases is herpes zoster with post-herpetic neuralgia, as it has been stated elegantly by Dr. Abdullah. The classical features of herpes zoster and the neuropathic pain, which is usually the feature of post-herpetic neuralgia with, so the right answer is number 2, which is almost 82% of you has answered correctly. So thank you. Next. Okay, risk factors that increase the likelihood of herpes zoster and its complication include all except, of course, age, advanced age is one of the risk factors. Diabetes is one of the major risk factors, as it was stated by Dr. Abdullah. Hypertension as well. But the one which is not a risk factor is a regular exercise, which 75% of you has answered correctly. So thank you so much for all of you. And we'll continue, Dr. Abdullah. Tafadhal.
Okay, thank you, Dr. Ashraf. Another scenario, we have a patient, 70 years old, with past medical history of hypertension and coronary artery disease. So the patient had an episode of herpes zoster 1 year ago. And since Rami had a herpes zoster infection 1 year ago, then he is unlikely to have a recurrence. I'm sure we tackled this information. So if you had one infection, there is still a risk. So the statement is false. So regarding the herpes zoster can strike more than once. Yes, approximately 1 to 6% of individual will be at risk for a second episode of herpes zoster. So, and the rate is higher, especially if the patient is immunocompromised or they are elderly with comorbidities, i.e. diabetes or CKD or cardiovascular disease. So we have to be careful. And this very important information need to be tackled with our patients. So the recurrence of herpes zoster is more likely in patients with underlying comorbidities, including diabetes and CKD. Interestingly, if you can see this graph in your left side, where the x-axis for the years of incidence of herpes zoster and the y-axis for cumulative herpes zoster recurrence probabilities. Interestingly, they found that patients in the age group of less than 50 with underlying comorbidities, they had the highest risk of recurrence, where the patient above 50, they had the second highest risk for recurrence. So again, it's very important to consider the risk and to discuss this issue with patients, because the majority, once they develop the herpes zoster, they think that they are not more prone to have, let's say, recurrence. So this information need to be discussed with our patients. And overall, in the right side, you can see that the overall patients with underlying comorbidities, they had 30% an increment in the risk of herpes zoster recurrence. So as much we have, let's say, if we have an underlying conditions of CKD or dyslipidemia, diabetes, cardiovascular disease, hypertension, so up to 30% of patients with such comorbidities, they are at risk to have recurrence. So again, this is very important to be aware about it. So regarding the treatment options of herpes zoster, unfortunately, it is a suboptimal. And we have to have an effective strategies. In our clinic, if the patient presents with herpes zoster in acute phase, usually the antiviral is the first choice to start with. And unfortunately, the patients, sometimes they are not presenting in 72 hours of the rash onset. So once the patient presented with a delay, so the effectiveness of antiviral will be less. So the majority, the treatment is often not achievable. If the patient presents with herpes zoster pain, simple analgesia or combined medications is required. And again, even for the combined treatment for post-herpetic neuralgia are optimum, and the majority of patients, they required high degree of polypharmacy or refer to, or they may need further referral to other clinics like pain clinic. As a prevention, all of you know that we have in early 2006 the presence of the LIF vaccine, Zostavax. It's indicated for patients, for patients with age more than or equal to 50 years. It's a life attenuated vaccines, and it's a contraindicated immunocompromised population. Since 2017, at which there was introductions of recombinant zoster vaccines, or Shingles, it was, let's say, it's a recombinant non-life adjuvant vaccine. It has a good advantage when we compare it with the previous vaccine, and it is indicated for the prevention for herpes zoster and post-herpetic neuralgia for adults more than or equal to 50 years, and even for adults more than or equal to 18 years of age, especially if they are immunocompromised or they are at risk to develop herpes zoster. So these are the new concept or the availability of new vaccine. So when we talk about the vaccines, recombinant vaccine, it is an non-life recombinant adjuvant vaccine, and this is an advantage. It is designed for older adults and at increased risk populations. Interestingly, the advantage of the adjuvant system, it boosts the immune response. So it leads to a strong and specific long-lasting immune response against varicella zoster virus, and it targets the decline in the specific cellular immunity in older adults and those who are at high risk. So these are the advantage of such vaccine. We have, regarding the vaccine efficacy based on different studies, that they found that the vaccine, the varicella efficacy vaccine, was similar in all age groups. And interestingly, they found that the efficacy reach or exceed 90%, and even reach to more than 97% for the age group more than 50. And that was noticed in ZOE 50, and even for long-term pooled ZOE 50 and 70 patients, or the efficacy for the vaccine, even for the age group more than 70, it exceeds 90%, and even for the complications. So interestingly, the patients for post-herpetic neuralgia efficacy reach even more than 90%, and it reached to 88% for the age group more than 70. So we spoke about the advantages and the difference between the old and the new vaccine. We should not forget that with any vaccine we have, let's say, side effect. So interestingly, the overall incidence of serious adverse effects were similar between the recombinant zoster vaccines and the placebo based on different studies. So there was no, let's say, serious adverse events. And the majority of patients, they present with local symptoms like pain or redness at the site of injection, and some systematic, let's say, symptoms in terms of myalgia, fatigue, headache. And that we have to look at from the bright side, that it's a good indication that this patient, if the patient develop such, let's say, a side effect, this is a good response that the immune system is functioning, and we should assure our patient, and this is the good sign. And interestingly, the vaccine compliance was higher, and more than 94% of our patients, they are retained for a second dose. All of you know that we have 2 doses of the vaccine in 2 to 6 months apart. So regarding the side effect, even in people with comorbidities like diabetes or others, the number of serious side effects were similar in both vaccine and group and the placebo group. And there was no safety concerns were identified based on different comorbidities. So again, with ZOE or long-term follow-up studies regarding the vaccine against or for the age group more than 50. So interestingly, the more than 79% they showed, let's say, prevention, and the same thing for secondary endpoint regarding the efficacy for herpes zoster for 1 month after the second dose. It reached to almost 87%. And if that was the finding for the follow-up study, which extended up to 11 years after the second dose in ZOE 50 and 70 studies. So back to the vaccine, recombinant zoster vaccine, it is a non-life G subunit vaccine, had an adjuvant system. It's indicated for the prevention of herpes zoster for patients more than or equal to 50 years, and for adults more than or equal to 18 years at increased risk for herpes zoster. This vaccine administered as 2 doses, intermuscular, 2 to 6 months apart. Usually there is no contraindications. It can be even given in immunocompromised in a short term. So we can give, let's say, the second dose 1 to 2 months after the first dose when we consider, let's say, the benefit. So this is very important. And the vaccine, even it can be given in immunocompromised, and there is no contraindication unless the patient is hypersensitive to the vaccines or its component. So again, we may go with acceleration, especially in immunocompromised. So we give the first dose, and the second dose can be given 1 to 2 months after the initial dose. If the patient, for example, in chemotherapy, or the patients in low immunity or immunocompromised, so the benefit will be more if you give the 2 doses in short term as an accelerated. Otherwise, we go with the same, let's say, interval of 2 to 6 months apart from the first to second dose. It's a 0.5 ml injection vaccine. Another important clinical scenario, we face it in our clinic by our patients. Can we co-administer the vaccine with other adult vaccines? In our clinic, we have, let's say, seasonal influenza vaccine, we have pneumococcal vaccine, we have pneumococcal 13 or 23, we have DTaB, tetanus and diphtheria, and cellular pertussis, and we have a coronavirus vaccine. So you will or you maybe face such questions from your patients. Doctor, can I receive different vaccines at the same setting? Interestingly, based on different studies, they found that co-administrations showed no concerns regarding the safety, and there is no evidence of interference in the immune response to any antigens in either vaccine, whether varicella vaccines or other vaccine. So it can be given safely without, let's say, concerns in terms of interactions or interference, or regarding a safety concern.
Okay, thank you, Dr. Abdullah. Now we'll go for another set of knowledge check. So again, scan the QR, and we'll move to the 6th question. So the question says, what is the recommended dosing schedule for RZV in immune-competent adult? Single dose annually, 2 doses 2 to 6 months apart, 3 doses 1 month apart, or 2 doses 1 week apart? So 30 seconds to answer the question. Okay, the next question. what is the vaccine efficacy of RZV against herpes zoster in adult aged more than 50 years? Is it 50%, 75%, 97.2%, or 85.6%? The third question, in which populations is RZV contraindicated? Adult aged more than equal or more than 50 years, immune-compromised individuals, individuals allergic to vaccine component, adult with diabetes. Okay, so we'll see the answers now. Oh, there is one more. Which one of the following vaccines can be safely co-administered with RZV? Seasonal influenza vaccine, pneumococcal conjugated vaccine, COVID-19 mRNA vaccine, or all the above? Okay. All right. So we will have the answers. So the first answer for the first question is, what is the recommended dose schedule for immune-competent adults? It is 2 doses, 2 to 6 months apart, and this is almost 80% of you answered correctly. So this is a very solid statement that we have to remember while recommending the vaccine for patients to have the first dose and the second dose between 2 to 6. And usually we prefer within 2 months, not to have a long period of time so the patient might forget the second dose, which is very important. The second one, what is the vaccine efficacy against herpes zoster in adult age more than 50? So it's 97.2%, as many of the studies has shown. So the efficacy is more than 90 plus. So this will give us quite reassurance that the vaccine is efficient to induce the immunity that is required. What is the vaccine efficacy? This is okay. The next, in which populations is the vaccine contraindicated? It's not contraindicated in adult age more than 50. Actually, it is recommended. That's also recommended in immune-compromised individuals and in adult with diabetes, but it is contraindicated individual with allergy to vaccine component. So about 68% of you, so majority of you, to answer the question correctly. Okay. Which of the following vaccines can safely co-administer with RZV? Dr. Abdullah mentioned it very clearly that according to the recommendations, multiple vaccines can be co-administered together at the same time. So this should not be counted as a missed opportunity that the patients who is required to have the vaccine comes without having it. So you can give it all. So you can give the seasonal vaccine, influenza vaccine, pneumococcal, COVID, along with the herpes zoster vaccine as well. Next. So I would like to thank you, Dr. Abdullah, for the wonderful presentations. You have highlighted the herpes zoster cause of the disease and the herpes zoster with association with comorbidities and how the comorbidities increase the risk of herpes zoster infections. And you tackle the post-herpetic neuralgia, which is quite incrementally increase in incidence in patients with diabetes. And you have highlighted a couple of clinical cases, which are quite illustrative. And then you mentioned about the risk factor for increasing the herpes zoster, recurrence of herpes zoster, which is a very commonly and frequently asked questions. And then finally, you ended your presentation with the vaccine showing the efficacy, the safety, and durability. So with this, ladies and gentlemen, I would like to, on your behalf, thank Dr. Abdullah for his wonderful presentations. And I think the time comes to highlight the questions that we have here. So I would like to ask the two speakers, Dr. Faiza, Dr. Abdullah, to be on the screen so they can receive the questions. In fact, we have received a couple of questions, which is quite interesting. One of the questions for Dr. Faiza, this is a common question that, we are all engaged with the transformation of our healthcare system to secure the best interests of our patients. And now we're talking about quality of life, and we're talking about population health. And this is one of the major roles that we are expecting the family physicians and the primary care to be the champion of this kind of change. So the questions: how can healthcare system integrate lifelong immunization into the routine adult healthcare? So, the immunization for adults should be integrated in every single encounter, should be integrated in every single policy that we are concerning the populations and the other populations. So how you look into this kind of concept, Dr. Faiza?
يعني using immunization as a basic life as like one of the elements that medical or healthcare worker should provide to each of his patients, and as a strategy that even all elderly needed. First, by assessment, if patient received vaccination or no. If did not receive vaccination, maybe he would ask him why he did not receive. Maybe he can discuss with him his concept and idea behind delayed vaccination, if there is an issue regarding this, and try to convince him and talking with him as or her with the same language and elevate awareness for his patient, and deal with vaccination as one of the medical management that each patient has the right to receive it. Same as medication, as investigation, as follow-up. It's the same. Should be provided to all and discussed with each patient.
Excellent. Well said, Dr. Faiza, and I would like to share with you our experience in this kind of enhancing our healthcare system in the International Medical Center, that we have put the prevention in all policies and vaccination in all encounters. So whatever decision is made in the hospital or in the healthcare system, we should identify the preventive measures to be one of the tools that has to be implemented in each policy, regardless the specialties and regardless the engagement of the work of any departments. And then we have identified vaccinations in all encounter. So every single individual, patient or visitor or anyone who is eligible to have a vaccine, once he's getting into the healthcare system or the healthcare premises or the hospital or primary care, he should be captured immediately by the system or by certain initiatives to not to have a missed opportunity, because these people, once they come to the healthcare institution, it's a golden opportunity for us to vaccinate them, because they are proactively coming to us. So we have to utilize this kind of. So we managed putting vaccines in all encounters. So our colleagues in orthopedics or in ophthalmology, where they don't have anything to do with vaccinations, they have been trained to identify those people who are potentially eligible to have the vaccine. For example, herpes zoster more than 50 years. So they are requested to be encountering the physicians in the vaccination clinic. So this was one of the ideas that we can promote our healthcare system to be more adaptive to this kind of concept. Dr. Abdullah, a question for you. Why we have a low vaccination coverage in the second dose of herpes zoster? We remember that many years ago, we started a campaign, and the first dose was quietly engaged a lot of people. But when it comes to the second dose, we find the vaccination coverage getting lower. Is it because of awareness? Is it because of we are not engaged much with our patient to remind them, or it's because of the healthcare system that doesn't have a reminders system, or the social media or the mass media, whatever? So what is your thoughts on this?
Interesting. I think it is multifactorial. There are factors related to the patients, factors related for, let's say, the physician, the one who is encountered with this patient, the healthcare system. So the vaccine or the availability of the vaccine, although to overcome such scenario in our clinic, we clearly sit with the patients and we educate them, and we try to make like a reminder. So a patient receive SMS or text message that they are due for the second dose. Patients, once we sit with the patients, we clearly stated that the coverage for or the prevention for this vaccine increased, let's say, to reach the maximum benefit if you take the second dose when we compare only on single dose. Interestingly, I noticed that even MOH started now to send even because the program itself, it is registered in Hisn. So they are, let's say, seeing the patient who received the first dose, and they send an SMS to the patients as a reminder. So they came to different centers or different hospitals or the previous center at which they received the first dose. So again, it's a multifactorial. We need to, from our side, we need to sit with the patient to clarify the importance of second vaccine and its efficacy, especially after the second dose. And this is in terms of patient factor. Again, if they are not compliant, so sometimes we may face a bit challenge. But from our side, we try to make it clear from the beginning.
Excellent. And I think the gap between the 2-month and 6-month was quite wide. So what we did, we tried to promote the second dose to be on the second 2-month from the first dose. So this within the narrow gap between the first dose and second dose, it will highlight the importance and the compliance, and the patient always remember this. But if you give it in a gap of 6 months, it's always getting forgotten. And as you have said, Dr. Abdullah, the importance of having the second dose to complement the first dose efficacy and to boost the immunity and to protect the patients who especially who are vulnerable. Dr. Faiza, we're talking about the immunosynthesis effect, and those people with elderly patients, they get their immune system getting compromised because of the aging. But will this immune synthesis affect the response to the vaccine? So definitely, being an elderly patient, the age is a factor for making the patient vulnerable to the infections. But is the age is a factor to make variability in effectiveness of vaccines response?
Yes, for sure. It affected the immune. They have a different or weakened immune response to vaccination. So there was a different strategy to overcome this by increasing the society all vaccination and augmenting herd immunity. Or using adjunctive agents or changing the technique of giving the vaccine. One of these is giving the booster doses and the second doses, like Dr. Abdullah mentioned for shingles. This will promote and enhance the effectiveness of immunity. So they might, yes, they will need this immunosynthesis will affect their response, but it can be overcome by other strategy and different strategy. One of them is herd immunity, and increasing all society compliance to vaccination, giving the booster doses or second doses, and following other techniques.
Excellent. Dr. Abdullah, what if the second dose was missed for more than 6 months? What do you recommend?
Okay. This is good questions. Maybe the team from the Shingles vaccine, they have an idea. And yeah, yeah,
I give it as soon as I remember, or as the patient remember, I'll give him the second dose, because I don't know. We have to clarify this because still we have to have the data.
Yeah.
But I think this is our practice now, that whenever it's remembered, even after the period of 6 months, we usually give the booster dose in a hope that it might enhance the immunity somehow. So دكتور عبد الله برضو في عندنا موضوع اللي هو طيب now the demographic of our population, the kingdom has been changed. So now the lifespan of the population is getting older because this is one of the target of our healthcare transformations, the lifespan from 78 up to 81 years by the year 2045. And the increase of the prevalence of chronic disease and increasing the new populations of geriatrics above the age of 60 and 65. How do you secure the population health with this kind of confounders that will push our patients and the population into the risk of infection? So if there is any major strategy you can forecast to counteract these kind of epidemicity of being older and having comorbidities?
Yes, I think our role is mainly in increasing awareness since we have this vulnerable age group. So increasing awareness by campaign or even in our clinic setting. So with the availability of such a vaccine, which is so far recombinant vaccine, it is safe. So we are doing our best to recommend it, especially for this age group with availability. And it is now, fortunately, it is a free vaccine. So again, it's very important to recommend. It's part now of the major guidelines worldwide in term, for example, in diabetic guidelines, like in American Diabetic, they recommend it. So in our clinical setting, we recommend for any patient above 50. So Shingles need to be discussed with the patients to discuss the benefit, the possible side effect, and with that, at least to highlight an important preventive role with the availability of such vaccine.
Thank you so much. There is an interesting question, Dr. Faiza, from Dr. Hind Al-Tahir. She said, can patient diagnosed as a post-herpetic neuralgia without history of skin rashes or even a scar? Or post-herpetic neuralgia is a prerequisite to have the full-blown picture of herpes zoster infection? Dr. Faiza, معنا؟
Yes, please.
Okay. السؤال بيقول دكتورة هند بتقول can patient diagnosed as a post-herpetic neuralgia without history of skin rashes ممكن؟
Yes, it can be presented as subtle symptom, يعني old infection, but it can sometimes present with only complications.
Okay. تمام. طبعا يعني this is one of the complication which is usually being encountered, and it's a worse complication of herpes zoster, the post-herpetic neuralgia. And most of the time we try to avoid this kind of neuropathic pain by using the high doses and combinations of pregabalin, gabapentin, duloxetine, tricyclic antidepressant, lidocaine patches, and all of these things, but it just reduced 30 to 50% of the pain, and the patient's still quality of life will be compromised. So this is how we look into the complications and how we can prevent this complication by vaccinating those patients at risk of having the disease. There is a question says that they have identified the age of 50 and above for herpes zoster and the age of 60 and above for RSV, respiratory syncytial virus. So why this kind of variability? And this is quite confusing to many of our colleagues in primary care to remember the age which is recommended for each vaccines. So any thoughts? Dr. Faiza?
It's mainly related the type of
Trials and studies.
Vaccine. The vaccine usually recommended based on the study of the of a specific population. So when it's well studied in an age group that is really vulnerable or have if they saw that this disease has a high mortality, high morbidity in this age group, they will study the vaccine effect first on them, looking for a better, looking for to improve the burden of the disease and prevent complication. So usually it's not that big difference, since it's approved by FDA above than 18 years of age. You can give it once the patient has a comorbidity or other immunosuppressions, or elderly patients like 60 or 50.
Yeah. There is another question, Dr. Faiza, from Dr. Walid Hassan. How to manage pregnant has a close contact with herpes zoster infected patient? Any recommendations for pregnant who is contact with herpes zoster infected patient?
Yes, vaccination can be given to a patient who is vulnerable to a disease, but usually shingles can be transmitted by that direct contact to the skin tissue, to the affected skin. So by avoiding this and following proper hand hygiene, avoiding contact with affected skin, especially if patient is immunocompromised or at risk. Otherwise, if he's one of the category that vaccine can be given to, they can give vaccine. This will prevent the disease for them.
Excellent, excellent. In fact, I'm just reviewing the questions in the Q&A box, and I'm receiving a lot of thanks for both of you for the wonderful and informative presentation that has been delivered. Many of the audience expressing their thanks to both of you. Question for you, Dr. Abdullah, and already you have mentioned it in your presentation, but for the sake of courtesy, I have to say it. Elderly patients came to take herpes zoster, pneumococcal vaccine, influenza, and RSV in this kind of season currently. So which one you give and what combinations you will recommend? As you said, you can give everything all together, right?
Yes. If they can accommodate, since there is no concern regarding the safety or let's say the interference, so it can be given. It's a good opportunity. So it depends on the patient, although there is no clear contraindication to give the vaccine to it.
Okay, well said. I think this is all the questions, but there's many repeated questions. So my apology to the audience. So we cannot take a repeated question. So before we close, I think Dr. Abdullah, Dr. Faiza, in a very short statement, what recommendations or what take-home message you would like to deliver to our audience, especially the primary care physicians and family physicians, to enhance their role as a gatekeeper in the healthcare and the first contact with patients and those people we are sitting in the gatekeeping, identifying those people at risk. So what recommendations would you like to deliver as a take-home message in one statement? Dr. Abdullah?
Yes, I believe we have a good tool in our hand. And interestingly, based on studies that the acceptance of taking the vaccine reach up to 25% for our patients, it can increase up to 75% if this vaccine discussed with the caregiver or the physician. So there is, let's say, an interesting shift to convince the patient about taking the vaccine based on available evidence, based on available efficacy, to avoid, let's say, the associated devastating complications, i.e. post-herpetic neuralgia, especially in patients with comorbidities.
Excellent. Dr. Faiza, تفضلي.
I would like to emphasize on the key role of each healthcare worker. Their role is to deliver this awareness to our community, our beloved, our patients, to take benefit of vaccine and understanding the value of vaccination is our role to be delivered to our patient and society. So just try your best to deliver.
Okay. Thank you so much, Dr. Faiza, Dr. Abdullah. And now, ladies and gentlemen, we are coming to the end of our sessions. But before we close, we would like to hear from you. How was this session? Was quite satisfying for you? So this is a satisfaction survey. Please scan the QR, and we'll move to certain questions. So the first questions, to which extent event content met your expectations? So you have a scale from 1 to 10. 10 is high, 1 is low. So we can go ahead. This is a very important survey for us to upgrade and uplift our way of presentation. So it will be appealing for all of you to get you engaged and to get you in a position to capture those informations and updates. The second question is, to which extent was the quality, knowledge, and flow of the chairpersons and the speakers? So scale from 1 to 10. Would you recommend future meetings to your colleagues? Yes or no? And then overall, how would you rate the meeting? So we have another scale from 1 to 10. 10 is high, and this is the QR code. So I think it's my turn now to say my take-home message for all of you, ladies and gentlemen. It was a very pleasant session where we stayed together for almost 2 hours, highlighting the different parts of our topics. So I would like to conclude by saying vaccination is not just for children. And this is a fact that majority of our populations who are resistant to have the adult vaccinations because they realize that it's just only for children. So it's a momentum for us, to change this mindset up and to get them engaged. So adults need immunization to prevent serious infectious disease. It has been counted to be more than 18 to 20 different diseases that can be saved and prevented in elderly patients. Why? Because these vaccines reduce the morbidity and improve the population health. 1 in 3 individuals with will develop herpes zoster shingles in their lifetimes, with the risk increase significant after the age of 50. And Dr. Abdullah highlighted certain group of population at high risk, those patients with diabetes, with other comorbidities, and the more comorbidity association, the more risk for the patients to have the disease and the complication of the disease, which is post-herpetic neuralgia. The recombinant zoster vaccine provides 97% efficacy in preventing the shingles. And this is a very important statement, a very important data that you can disseminate and convince your patient to have the vaccine by having this high level of efficacy to induce the immunity. Administered in 2 doses, remember that administration between 2 to 6 months apart, ensuring a strong and sustained immunity response. So with this, I would like to end my sessions by thanking all of you for being available with us for the past 2 hours. On your behalf, I would like to thank our guest speakers, Dr. Abdullah Zahrani and Dr. Faiza Nahdi, for their wonderful contributions and enriching our scientific event with a lot of updates, graphs, and informations, recommendations, wonderful and fruitful discussions, which was ending our scientific event. And I'm sure that all of you will carry whatever we have discussed today to be part of your clinical practice tomorrow onward. Try to identify those population at risk above the age of 50 and try to allocate all the resources in your primary care center, in your healthcare facilities to capture this opportunity, not to be missed opportunity of having those people leaving your organization without having the vaccine. Try to work hard along with the multidisciplinary team to abort the vaccine hesitancy and to engage all the healthcare providers with vaccine recommendations. And ultimately, we can safeguard our populations and move towards a vibrant society that will give us a thriving economy and then ambitious nations. مجتمع حيوي، اقتصاد مزدهر، ووطن طموح بإذن الله. مجتمع حيوي. This is our responsibility to safeguard them and to give them the best care that they deserve. With you, I would like to thank GSK, and I would like to thank the Saudi Society for Family and Community Medicine of having this kind of scientific event. So stay tuned with us, and we will move, inshallah, with another episode. Thank you for FEXS, for the wonderful organization, and have a wonderful night, ladies and gentlemen. Assalamu alaikum wa rahmatullahi wa barakatuh. يعطيكم العافية دكتور عبد الله. شكرا دكتور عبد الله. دكتورة فايزة. Thank you so much. نلتقي إن شاء الله عن قريب بإذن الله.
شكرا، يعطيكم العافية.
شكرا لكم.